Good morning, everyone. Thank you for joining PHCA for today's webinar, Community Health Choices, Southwest Nursing Facilities Lessons Learned. I'm Wendy Johnson with the Pennsylvania Healthcare Association. Before we begin, I have a few housekeeping items to cover. This webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for 1.5 continuing education credits for PHCA members. Credits will be uploaded to NAB within the next 2 weeks. I will be sending a link to a quick survey. Your feedback is important to us. All attendees will be in listen-only mode. However, throughout the presentation, please feel free to submit questions using your questions pane on the right hand of your screen, and our presenters will address them throughout the presentation after each specific section instead of waiting until the end of the webinar. So that is a little bit different for us. We will be answering questions throughout the webinar on specific sections throughout. Now for today's webinar. Today's webinar is being presented by PHCA members who have experienced community health choices in Southwestern Pennsylvania this past year. The implementation of CHC program promises historic change for long-term and post-acute care providers in Pennsylvania. Since January 1st of this year, your colleagues in the 14-county Phase 1 zone have been operating under CHC. This webinar will allow you to learn from your peers that operate nursing facilities in Phase 1 zone. The presenters will share the steps they took to prepare for implementation and some of the challenges and successes they experienced. Presenters will offer insights regarding contracting, claims processing, working with service coordinators, transportation services, participant enrollment and eligibility, working with the IEB, and other issues they faced under the CHC program. I'll now turn the webinar over to Mark Fox.
Good morning, everybody. I know we're going to get into a lot of detail here as we travel through the webinar, but I wanted to start with just some basic information and an overview that I think helps to understand the program and perspective as we go through the details. So let me first start by saying, before the state launched here in January, 22 other states had already started what they called MLTSS, which stands for Medicaid Managed Long-Term Services and Support. So what we had done at Grain was we had talked to some of those other states, and New Jersey, New York, and Ohio were some of the states that we had talked to and gathered up some information prior. And every state that we had talked to had a little different twist on MLTS, but there were some similar things. So some of the things that we're going to talk about here with Kim Bowser and Sherry, a part of Grain, came as a part of our conversations with those states. So if we go to slide 4, I want to just talk about the overview for just a second. First of all, I think it has to be said that the state is out of the Medicaid business. What I mean by that is they're not administering the program, they're overseeing the program, and what they've done is they've contracted with 3 organizations. They've contracted with UPMC, which means University of Pittsburgh Medical Center, Centene, and Caritas. Now, those have different product names, and some will even try to change product names in the markets they're in. But those are the 3 contracts they have. And that's important to recognize because while you might have before talked to the state about questions on billing or administering the services, many of the questions now will be turned over to the contract services. So I think it's, again, important to say that Medicaid is essentially out of the business. They're overseeing the program, and they've contracted with the 3 organizations. I think the other big thing to recognize at the outset is essentially 70% of your patient days will now be in what I would consider managed care through these 3 organizations. And while initially it's kind of a soft managed care, what we look going forward will be it may become a little bit more aggressive in what you're more familiar with in the other Part A managed care experience. So many of the changes we did and many of the things we did to get ready were centered around these things, including seeing that 70% of our patient experience now is going to be in these 3 contracts in essentially managed care. So I want to introduce now to you Kim Bowser, who has overseen our assessment coordinators for many years, as well as overseeing managed care in our 12 buildings. In addition, Sherry Lord oversees our central billing and has integrally been involved here as we implement. So I'll turn it over to Kim Bowser.
Good morning. The goals of this PA's CHC programs initially were to enhance the opportunities for community-based services, strengthen healthcare and long-term care services and support delivery services, allow for new innovations, promote the health and safety and well-being of enrolled participants, and ensure transparency, accountability, effectiveness, and efficiency of the program. The enhanced opportunities of community-based services, the program itself, I do want to point out, is a lot of the members are assessed on admission to see if there is the possibility of them being discharged with additional community services that previously would have been long-term care patients. So you need to keep that in mind, that there are some additional community services that they are assessing the residents for. Next slide. The 3 managed care plans that Mark had talked about, AmeriHealth Caritas, which now will be called Keystone First, UPMC, which is the University of Pittsburgh Medical, and PA Health and Wellness. These 3 plans will be rolled out statewide, and your facilities will need to contract with all 3 plans if you wish to accept residents enrolled in the CHC. Contracting with these are similar to contracting with any other managed care organizations. So it is not a process that occurs within a couple of weeks. So if you have not started that process, you're going to want to begin looking into that. Next slide. So who is affected by the CHC? It's dual eligible individuals, MA residents residing in a nursing facility. Currently, they're already on an MA benefit, MA recipients receiving long-term care services and support through one of the Medicaid home and community-based waiver programs. And the LIFE program will continue to be an option in addition to the CHC. So if your patient is already enrolled in a LIFE program or chooses a LIFE program, that would be an option for them. Next slide. So the MA eligibility. They have to meet clinical eligibility requirements. Those will be conducted by Aging Well, which is a AAA entity. They will have a functional eligibility determination form, which the new form implementation will actually be September. The primary information when they enter your building to determine clinical eligibility will be taken from the MDS itself. They will use that as their source when they are in your facilities. The functional eligibility will be completed on computer, and it includes questions necessary to determine nursing home clinical eligibility. It ensures the consistency across all assessors. Next slide. Enrollment in CHC managed care. So enrollment packets will be distributed to all of your dual eligible residents. They will be able to select a plan by a specific date, or they will be auto-enrolled. Enrollment options are either by mail, telephone, email, or online. The SNF cannot make recommendations or steer residents to a certain plan. I can tell you that we had a large number of residents and family members who had some difficulty as far as the enrollment online. So our staff was able to help them actually get onto the website while they were in the building. And that way, if they had any technical questions as far as the enrollment, they could be there to answer those. They can change plans at any time. There's some dating rules. So before or on the 15th of the month, it would go into effect the first day of the following month. If they choose to change plans after the 15th of the month, the effective date would be the first day of the second month after the selection plan is made. Next slide. If the enrollment date, if on the enrollment date that the individual is residing in a nursing facility that is a network provider in only one MCO, the individual will be enrolled in that MCO if they did not choose an MCO on their own and they're being auto-enrolled. Second, if the individual is enrolled in a DSNP, the individual will be enrolled in the managed care organization that is aligned with the DSNP. Third, if the individual is transferring from a Health Choices and is a member of a Physical Health Choices MCO that is a CHC MCO, the individual will also be enrolled in that particular CHC MCO. And last, if the individual's PCP is a network provider with only one CHC MCO, then that individual will be enrolled in that particular plan also. Next slide. So, selecting an MCO. There is online training that is available for the nursing facility staff to better understand the process. The SNF can assist the resident or family with enrollment. Like I said, we did have some families that we set up on a computer in our buildings to help them with the technical part of enrollment. One of the big concerns, network providers, we need to ensure that our primary care physicians and our ancillary providers, along with our nursing facilities, are enrolled in the MCOs that the residents' families are choosing. We had a particular handful of physicians who were not enrolled in one particular plan in the Southwest region. So we just made the family members aware. You can choose this plan, however, we do want to make you aware that your primary care physician does not participate in that plan. So they needed to know their options of either changing physicians or choosing another plan without trying to steer them one way or another. The independent enrollment broker, they're to provide choice counseling during transitions to CHC and ongoing as residents apply for MA nursing facility services. We have not had a large participation from the IEB itself. So, next slide. Impacts on operations. So the MDS data, like I said, is part of, it's the main clinical resource for your service coordinators. So the department intended to require that all participants receive a comprehensive assessment using their inter-RAI assessment form. The plans and associations pushed back, and DHS agreed to allow the plans to use the MDS data. Challenge is how to share that data with the plan the resident is enrolled in. We chose to give them electronic access to the residents who were enrolled in their plan. And when I say they, I'm referring to the service coordinator from each designated plan. They have electronic access when on site in our facilities to those particular residents who are enrolled in their plan so that they can pull the data that they need from the MDS. Next slide. Service coordinator. The service coordinators will be assigned to residents. Each facility is assigned a service coordinator. However, if a patient is enrolled in a CHC program in the community, you may have more than one service coordinator for the same plan coordinating services in your facility, because that service coordinator will follow the resident through your facility if they were receiving community services. Service coordinators are your key contacts for each of the CHCs for reporting of your critical elements, authorizations, sentinel events, and etc. You do need to keep in mind that the service coordinators, a lot of them are very new to the long-term care arena, and they will require a lot of education from the skilled nursing facility staff in regards to the daily operations, regulations, and etc. of long-term care. They do need some guidance as far as how the long-term care process occurs. Next slide. So, suggestions. Because your residents can change plans at any time, we strongly recommend that you develop a tracking for your residents' enrollment. Monthly, the facilities are verifying online each resident's plan enrollment. And in addition to that, we are verifying it with the individual service coordinators from the plans. We also go into the promise system because it does not always have the same information as what your service coordinators will have. However, the online system is the final say. So we are frequently actually updating the CHC service coordinators as to what residents are actually enrolled in their particular program. We have developed tracking of all of our ancillary and primary care physicians and assisted them. We get on and monitor to ensure that they are enrolled and what plans they are enrolled in for all of our facilities. And we have actually assisted them with contact information and contracting information so that they can obtain those contracts with the CHCs also. Your RNACs and case management departments must work collaboratively in order for the CHC organizations to have all required information. We have actually combined that and made one department for the RNACs and case managers in most of our facilities so that that increased communication takes place, because MA is essentially just a managed care program now. Next slide. So any questions from our information that we presented?
Before we get into questions, and this is Mark Fox again, I wanted to just add a few points to what Kim is saying, because I get a lot of phone calls from the other sections of Pennsylvania, is how many folks we've seen transition out of the nursing home. The numbers that we had seen initially that were provided by the state were 66, but in talking to our buildings and other buildings in our markets, it's not an unusual number. They would be typically, you know, those people who would be transitioning out of our facility anyway and going home. So we don't see any extraordinary activity in that regard. Secondly, people ask me about enrollment. We saw the initial enrollment when people were selecting a very light participation. You know, one of our buildings might have had 5%, maybe up to 10% elected on their own. And then most of it was the passive enrollment or the auto enrollment. At which time, the other odd thing that we realized there was, you know, we thought it was going to be 30-30-30 with the passive enrollment. They adjusted that passive enrollment based on the initial enrollment election, so that eventually what they were trying to reach was a 30-30-30 after it was all said and done. So it's a little odd in the auto enrollment, but in the end, they're trying to reach a 30 33% for each of the managed care. And then the final point I'd like to make is the important thing here is making sure you separate enrollees into track them carefully, because as Kim mentioned, they can change any time. So you have to be very careful, intentional about making lists of all the people in which of the 3 programs they're in. And in addition to that, you have to be able to determine who are the players in each of those programs. For instance, you need to know the doctors in each of those 3. And you got to, some of them, we even had to make sure we had a doctor in the managed care contract. So the doctors that are in each, the lab that's in each, the pharmacy that's in each, the X-ray. That was an initial pushback, but eventually we got each of our services in the 3 different contracts. But that's important outside as well, is to get doctors, lab, pharmacy, and X-ray into each of those 3 contracts. So with that, I think we're ready for questions.
Hi, good morning. This is PHCA. We have a few questions I think I actually can answer. So the first question is, I would like to clearly understand dual eligible. By dual eligible, we mean someone that is covered by Medicare and Medicaid. So that would be a dual eligible. Next question, are you saying that only if the resident has Medicare that they are participating with one of the CHC, or anyone who has Medicaid? It's anyone who has Medicaid. So if you're in the community, you could be a healthy dual, meaning in the community not receiving long-term services and support. In CHC, you just won't be receiving long-term services and support at that time. So hopefully that clarifies. And the next question, if someone comes in long-term care with community Medicaid, will they keep the same service coordinator in the facility, or will they get the facility coordinator? My understanding is when they're in the community, they have a care coordinator, and then in the facility, they're going to get a service coordinator that's basically supposed to be specialized in nursing facility services. Service coordinators are using, the plans are using for the residents in the facility are going to be direct employees of the plans as opposed to a contracted service coordinator.
And that's correct. If the patient is long-term care, they're followed by the service coordinator in the facility. But if they are short-term, their community service coordinator, we found, is typically following them and through discharge.
Just a reminder for everyone, we're getting some background noise. If everyone can put their phones on mute as you're listening in, our speakers will be on mute unless they're speaking, but if everyone who is attending can put your phones on mute, we're getting a lot of background noise. Thank you. Thank you, Kim. We really appreciate your insight there, and we're now going to turn the webinar over to Tammy Desimone.
It's DeSimone. That's okay. Hi. Okay. Good morning, everybody. I'm going to talk about some of the advanced preparation that we did at Transitions Healthcare that might be helpful to everybody out in phase 2. So we'll go ahead and get started. Okay. Last year there was what I called a kickoff meeting, where all 3 CHCs came and spoke with different groups of people. I think they held 2 different meetings in the various area. I'm hoping that maybe they've already done this for your area. If not, the purpose of the kickoff meeting was to get initial information from the CHCs as to how everything was going to work. Also, it was real important to get contact information to set up one-on-one meetings with each CHC to more specific information regarding contracting, claims processing, rate setting processes, clearinghouse information for billing purposes, and all the other things. We found that this meeting was really, really important to get yourself in front of them, get the initial contact information. Also, in the future, as they go along, I would highly encourage everybody to attend all webinars, conference calls, or conferences that each CHC, PHCA, and the state of PA sets up, so that you can keep up to date with any new information that may be presented regarding everything I mentioned above: contracting rates, service coordination, orientation sessions for the facilities, anything to do with claims. So anything you can get your hands on, I would highly recommend that you attend. And you will not only see them come up as a group, but you'll also see the individual 3 MCOs come up with their own conference calls and webinars. Next slide. Go ahead with the next slide.
Tammy, I'm advancing. Aren't you seeing it?
I'm not seeing it, no.
Okay, hold on a sec.
It may be on my end.
I advanced it. I don't know why you're not seeing it. Tammy, can you just go? Yeah, because I think everybody else is seeing them advance. Would you mind can you speak from them? Do you have them?
I do. I'm pulling them up right now.
Okay, thank you.
Just give me just a second.
A little technical difficulty here. Sorry. We're all in different places, so it's kind of a challenge right now.
Just give me a couple more seconds. It'll come up. I'll just do it from my slide.
Okay. In the interim, I can just let everybody know that the department did do their kickoff meetings for Southeast. Hopefully you folks were able to attend. They were in June. They had actually 8 of them, I believe, in the different counties, in different colleges. They were really, I thought they were really well done. There was a lot of good information. We actually at PHCA, we updated our Q&A document that we're going to kind of show you where you can find that later in this presentation. That includes some of the information that was received at those provider summits. So hopefully that information will be helpful to you. Are you ready, Tammy?
Good. I'm back up. Yep. Okay. Thanks, Wendy. All right. The next thing, as far as preparation, I would highly encourage everyone to attend the annual PHCA conference, where you can attend presentations by each CHC to continue to obtain any new information and to get a status update as to where they are with contracting, rate setting, orientation, and claims processing. As you meet or talk to each CHC contact during one of your one-on-one meetings, and again, I would highly, highly encourage, I can't say enough, I would highly encourage each of you to get that one-on-one face-to-face meeting with the CHC, each CHC, because you can meet with several individuals who are in charge of the different areas, from contracting to claims processing, service coordination. We found that very, very valuable when we met with them. Get as much information as you can regarding transportation, such as which vendors are approved for use, authorization, payment, contracting, billing, clearinghouse information, etc. And I'm throwing out all of these different areas because these are things that you may not think of when you're meeting with them, but that's why I keep emphasizing all of these different things so that you can address them during your meetings. Next slide. You can go onto the PHCA website at least weekly to view any updates regarding the CHC and for any CHC questions and answer document updates. They put out, PHCA puts out a frequently asked questions document, and they update it from time to time. A lot of the questions you will see are repeated. However, there is also new information. So I would highly encourage you to do that at least once a week. As soon as you receive and execute a contract, you need to sign up each of your facilities for each of the web portals. We found this very valuable because when we got to this step, we had some issues signing up for the web portals. And it was due to the fact that, and I'm going to get to this in a minute when we talk about contracting, there's also a huge credentialing packet that is bigger than the contract itself. And there's a lot of information that they need to plug into their systems in order for you to get onto their web portals. We were finding that they did not receive or lost some of the credentialing information, and we were not able to register for the web portal. So we could get that straightened out right away. I would encourage you to do this. Give yourself enough time, at least a month in advance to make sure that you're all registered for your web portals and ready to go with each of the MCOs. Next slide. Also ensure that you receive a contact from each CHC for each area that you deal with: claims processing, contracting, service coordination. I can't emphasize this point enough. Be persistent until you get the information that you need. There were many times where I had to call one of the MCOs, and I just kept dialing different numbers until I got to the person that I needed to get. My best piece of advice to you is to not get frustrated. Just be persistent and keep going until you get the information that you need. Okay, next slide. Okay, so let's move on to contracting. This is all part of the advanced preparation as well. Again, can't say it enough. Setting up one-on-one meetings with each CHC regarding contracting is the most important step. They need to know the specifics of each of your facilities so that nothing gets missed in the contracting phase. For example, some of you may have vents in your facility. You want to make sure that information gets in your contract. Also, in terms of your rates, how are they going to set the rates? Make sure that hits your contract accurately. Which leads on to my next bullet point. Before you execute your contract, make sure that your rates, your daily rate, your transportation rate, your vent rate, are specifically stated in your contract. Just make sure there are no surprises there so that when you bill the first time, you're billing accurately and you'll get paid. Next. Okay. I mentioned these before. The credentialing packets are the key to getting each of your facilities set up in the CHC's web portal correctly. As I stated, they are twice as long as the contracts themselves. I know AmeriHealth is 13 pages long, just to give you an example. Credentialing packets ask for vendor information, physician licensure, individual nurse licensure information, individual nurse aide licensure information, and there's much more. And I put this in bold. It is extremely important that these credentialing packets are accurate the first time that you send them in. If they are not accurate, it will delay your contract. So please make sure that you have everything that you're going to send them right the first time. I would also recommend that, again, you keep a file in your computer. I would also keep a hard copy, because I will tell you that, as I said before, they may lose part of the credentialing packets or misplaced or not have received it, one of the many things, and you may have to send these credentialing packets multiple times. Next slide. Okay, after you complete your credentialing packet, as I said, keep a copy of it in case information gets lost at the CHC. If they lose your information, you will not be put into their web portal, and therefore you will not be able to sign up for their web portal and possibly not be able to bill electronically in some cases. As I stated, this was a real issue with them. So just be sure, can't stress it enough. Also, in your meetings, ask how your rates are calculated. And I know probably a lot of that has been presented already in your kickoff meetings that you had in June. I know probably at the PHCA conference, if they present, they'll be more specific on how your rates are calculated as well. Next slide. Get transportation and any other services that require specific rates, such as vents defined in your contract. Very, very, very important. Get a specific contact for each CHC regarding contracts. That way it all stays in one place. And make a list of all ancillary providers that bill MA directly to ensure they are included in the CHC MCO plans networks so that you can get paid. Next. All right, that wraps it up. So Wendy, do we have any questions from anyone out there?
Hi, Tammy. Thank you so much. Yes, we do. Gail's going to go ahead and read them for us.
Okay.
Okay. Don't doctor visits going under Part B, do all attendings for long-term have to be contracted if they have Medicare A and B? If the provider isn't going to be billing the plans for services, they don't have to be contracted and in network with the plan, because they're not supposed to have to change their Medicare physician. They're supposed to be able to keep them, but that's been a confusing area, I believe, for a lot of our facilities, because we've kind of been getting mixed information. So that's something that I don't know if anybody else on the panel can clarify how they've been seeing, what they've been seeing as far as that. Mark or Denise? Tammy, do you have any information on that?
No, I don't.
Okay, that's one that actually we'll take that question and do some research and get back to the person that asked the question. Actually, we're going to do a Q&A from this webinar, so we will get back to you on that answer. Okay, who is responsible for coordinating enrollment for PCPs and ancillary service providers, CHC service coordinators, question mark. The enrollment as far as, or I don't know if they meant enrollment for in the network or if they talk about enrollment for the residents. And enrollment in the network would be the responsibility of the provider to get into that CHC plans network. However, we've recommended to all our members, if you have ancillary providers that you work with on a regular basis that bill Medicaid directly, give a list of those ancillary providers that you work with to the plans so that they can reach out to those providers to get them in your network, in the network, because they are really interested in contracting with as many providers as they can, and they need that information to know who you work with. So that as a facility, I would recommend that you go ahead and make that list and provide that to each of the plans so they have that information, and then they can do some reach out. And you might even want to reach out to your ancillary providers that you work with in your buildings, let them know they should be working with the plans to get in network. Okay, so Tammy, we have one for you. Did the MCOs come to you for a face-to-face meeting, or did you go to them?
No, we went to them. So it was real interesting to meet with them and see the inner workings of the CHC, so to speak. We got to see how each of the facilities that were their individual facilities were set up. So it was real interesting. Again, I would highly recommend you go to them for that reason. And you got to meet with a lot more people versus I'm afraid that if they came to you, you would get one representative. So if you go to them, you're going to see several people and meet several people.
And we have one additional question. Who all needs access to the portal?
That would be, it's your business office folks, anybody who needs to obtain any type of authorization. I know you have your service coordinators that you work with a lot of the time. They may direct you to go into the web portal to get authorization as well. So at a minimum, I would have your business office folks. If you have case management in the building, give them access. Wouldn't be a bad idea to give your administrator access as well. and also your DON.
Okay, thank you, Tammy. We appreciate your insight there. And we're going to move on now. We'll have Shelley Phillips, who will do the next section on claims processing.
Yes. Good morning. Katrina and I will be presenting the claims processing. Next slide. So for your rates, verify with each one of the community health choices that the rate they have in their system prior to you sending your first claims. We found that there were some that even with the floor rates, and the floor rates being set by the state, that they did not match what this in each of their systems what the state said the rate should be. So before you send your claims, please verify that. Also ensure that each one of the community health choices provides you the additional dish amounts that they are going to pay you prior to your billing. AmeriHealth did get us that from the beginning, but the other two did not till a later date, and we have to go back and rebill those claims. So they will pay you that on a daily basis by increasing your rate for those buildings. Next slide. For your billing systems, AmeriHealth is built through MDON, which is also known as Change Health, and then we can do both PA Health and Wellness and UPMC through our third-party vendor. And we found it very helpful to have that vendor involved in the setup of these payers, and at times had both the CHCs and our third-party vendor on the phone at the same time and did like a three-way call to make sure everybody was on the same page. I don't have that on the slide, but make sure that you're doing your claims testing, that you start as soon as you can with them to work through that process to make sure that you're set up and that everything is running smoothly for you, so that when you go live, your claims will go out smooth. Next slide. Enrollment and eligibility. What we did is at the beginning of the year, we had every one of our BOMs run eligibility and promise to see what community health choice each one of our residents was in. We did get lists at the end of the year from each of the community health choices of who they thought were in their network, but when we checked promise, there were some, as was mentioned earlier, that were different than what promise listed. We had to wait about a week or so into the new year before they were all updated. For you guys, it might be an easier transition since we were phase one, but check those to make sure that what promise says is what you're using. Also, moving forward, as you have people that are pending and that are then approved, you'll need to look in promise to see when the community health choice start date is going to be. It'll list it in there for you. So it could be any time during the month. It's the date of approval that the community health choice starts moving forward, and then based on whatever somebody was admitted to you as, they will either be fee-for-service or 30-day Medicaid plans, or they'll revert back to the community health choice that they had coming in. Next slide. For applications, the process for you is not going to be any different. You're still going to need to do an application. You're still going to need to have a 103, MA51 options, all the supportive documentation. All of that is going to be the same. Paper applications can still be sent. However, you can also use Compass. And I have 8 buildings that were in phase 1 rollout. 2 of them are using Compass and love it. The other ones tried and they weren't real successful. There's sometimes they were getting kicked out and they would have to call and get their password reset, and it just, for some of them, they decided that they didn't want to use it. What Compass provides, though, is it date stamps your application for the start of the 45 days that the county has got to get you an answer. It also tracks the application, and it triggers the IEB to contact the nursing facility and that resident for the enrollment in the CHC. Next slide. And I will pass it on to Katrina. Thank you.
Okay, MCA requirements. Know what the requirements are prior to sending or creating your claims. That way, when you look over your claims, you know if the claim is correct and it's a clean claim when it goes out. If you get a rejection, you'll be able to know why that was rejected and what you need to fix. So you really have to talk to your local rep, or if you have a claims processing person you can get in touch with the MCOs. Make them like your best friend, because they are going to be the ones to help you get these claims to process correctly and pay. Some of the MCOs want the Medicaid number on the claims. AmeriHealth, they have a different identifier. They do not want the Medicaid claim. If you have somebody who has UPMC Medicare plan and a UPMC MCO plan, make sure you put the right ID number on that claim, or else your claim will not process correctly. If you put the Medicare Advantage claim number on there, it's not going to process correctly. Your revenue codes are not correct for the MCO plan. The MCO days, facility days, therapeutic leave, bed hold, co-insurance days, combination claims. Find out what the requirement is. How do they want those claims to go through? How many service lines do they want? It will be very beneficial when those claims process. Know there are requirements for adjustment claims. Do they want condition codes on there? Do they not want condition codes? Do they want the original claim number? Do they not? The type of bill. Do they want you to change your type of bill? Really get to know and understand what each MCO wants on your claims before you send them. Next slide. The web portals, each MCO, they have web portals. Use them. You can track claims, you can retrieve remits, see what the status of the claim is. The expected payment will be on there, and it could change from one day to the next, but at least you'll know what's going on. That way, when you follow up with the claim, you have this backup to show that your claim was sent and what it was showing, and if it's going to be denied and why. You can kind of get a head start on fixing it to get that claim to pay correctly. UPMC, they use the UPMC provider portal. PA Health and Wellness, they also have their provider portal, and it is very useful. It gives you a lot of information on there. And AmeriHealth, you submit through MD-On Office. However, the claims show up on Navinet as well as the remits. You will end up getting your remits through, you can view them on Navinet and print them. Register for those. Go through and look at those. Even if you're sending, you send one claim for each MCO, go to the portal and follow your claims so that you know what's going on. Next slide. This doesn't affect everybody, but it does affect some of you. Other claims, vent claims, DME, respite, transportation. Talk to them. Know what their requirements are. Where do you send the transportation claims to? Where do you send the vent claims and how? What codes do you need to use? It's very important to know those, because their system is going to process the claims based on the way they are sent, not based on how we can figure it out on paper, what should be paid. Their system is going to process it based on how that claim was sent. Know your expected payment, because if they process it and it pays wrong, you're going to know right away that claim did not process correctly, and you'll be able to follow up on it and understand what's going on. Make sure you know each and every detail for any type of claim for each of them. That's it.
Thank you, Shelley and Katrina. We really appreciate the information. There are no questions right now, but if you do have a question, please type it in your question pane and we will go ahead and answer it. Okay, seeing no questions, we're going to turn the presentation over to Denise Currie.
Hi, everybody. So I am going to speak to you just about some of the lessons learned as it relates to the service coordinators and the service coordination. So far, there's been a lot of expectations that have maybe changed, but when it comes to, at least in Southwest PA at this point, the building workflow, the expectations don't always meet, and a lot of things have remained the same from a workflow perspective for a lot of the facilities as it relates to service coordination. We are seeing that we spend maybe some more time on tasks in some instances, but it's not 100% that it's always going to be more time. Some things run just the way they generally always had. And we're seeing also, just generally speaking, that they are not as active in helping with discharges for maybe some newer 30-day MA plans that are CHC, but they're working more on the long-term service coordination. So just some things to kind of think about. Next slide. So I just wanted to make sure that everyone knew what the expectation was according to the department as it relates to service coordinators. You know, they are to be the people that are identifying, coordinating, and assisting with getting access. And they are really supposed to be working hand in hand with us and in social and housing services as it relates to in-home support. You know, the whole goal with the MCO is to make sure that the person is receiving their long-term support services in the right environment. Next slide. So where we've seen so far is that they are working at establishing goals with participants. And we do see that they are very helpful a lot of times with the long-term discharges from SNF to home community-based services that have long-term support and service needs. So they're helping with setting up home services, care services, and some community placement if home is not an option. Again, what we haven't seen as much of a robust assistance with yet is for those that maybe have a more skilled and short-term need, at least in our perspective, and it could vary between the different social coordinators, the service coordinators, is that they have they've really allowed the nursing facilities to continue to lead on the discharge planning with those people and maybe are just kind of put into the loop. One thing that has come up that I wanted to just highlight, and it's in the end of the presentation as well, and it isn't something that we saw at the very beginning, but I think that we're going to see an uptick with this, is the setting up of behavioral health services through the behavioral health MCOs. The service coordinators haven't been taking the lead at this point with that from what we've seen, but we do know that that is an expectation of the service coordinators. So something just for you to pay attention to and to make sure that you're speaking to your coordinators as you're working on your introductory meetings. Next slide. So we had a few slides that we thought, or a few tools that we started to utilize just to help us keep track of what was going on, because there are so many people that may be more, are involved with an individual outside of your facility. So one of the best practices we had in a couple of our Southwest Pennsylvania buildings was implementing a coordination log that allowed us to follow through and make sure that the tasks were getting completed. And it would help us keep track until things kind of settled into our new normalcy and we understood where things were headed. And on the presentation, on the notes section, and if you can't see it, between Gail, Wendy, and myself, we can get this to you. I know that this slide is really tiny, but the columns are labeled member name, the type of ancillary services, the procedure or test type, the reason for it, emergent, non-emergent, non-medical, the provider or location, the date of the procedure, whether or not the service coordinator approved it or is involved in it, that we have notified the patient and RP, and then what the contact name and date of contact was of that notification. So this is just one of our tools that we wanted to share with everyone that we thought was really helpful and just trying to keep track of who said what when for taking care of our residents. Another form, and this is a tweak of something as it when we first started, transportation was a really big issue. It still is a big issue, but it for a while required a log that we submitted to the MCOs. And what we did is we kind of kept that log going so that we could keep track of when transportation, so actually kind of phase 2 of the transportation issues that we have, is just keeping track of when the MCO was able to make the transportation and when we had to, just so that we could keep track of that. And again, just to highlight the columns in case you can't see that: member name, the date of the transport, the type of the transport, whether it was wheelchair, ambulance, or stretcher, the reason, again, emergent, non-emergent, non-medical, where were they going, the provider, what type of trip was it, round trip or one way, who is their MCO, was the provider able to schedule the transportation, yes, no, and then we highlighted the one that was a no. And then again, contact information so that we're keeping track of the proper notifications. Next slide. And then just for your information, in case Southwest or Southeast PA is hit with the same thing that Southwest PA was, this is the original log that the MCOs utilized for us, and we did this for the first 3 months of implementation. And then after that, in April, it became a tool that just like I said, some of the facilities utilized to just keep track of things. Next slide. And so finally, the last 2 slides for me are related to the behavioral health managed care organizations, because this is something that is new. It is a change, but it wasn't something that we saw in Southwest Pennsylvania immediately, but it will probably be something that they're going to be a little bit more organized as MCOs as they phase in phase 2. And that is all CHC participants will be covered by a behavioral health managed care through one of the existing behavioral health MCOs. And according to the guidelines, this is a change from aging waiver participants as well as nursing facility residents. Again, we didn't see it right away, but we're starting to see some changes with that now. And so I also included for you just the counties and what behavioral health MCO is going to be responsible for those counties. And that slide is going to be available to you in the attachments as well. And I believe that during the Pennsylvania Healthcare Annual Convention on day 3, there's going to be a panel related to the behavioral health CHC program. Thank you.
Okay, I just want to add something on behavioral health. We've had, this is Gail from PHCA, we've had communications with behavioral health MCOs, and they are very interested in working with facilities. The challenge is how to best communicate with the facilities. We had one webinar that was done by one of the behavioral health MCOs. We have another one that we're probably going to do with Magellan. All of them have agreed to be on the panel that Denise just mentioned, along with OMSOS, which is the office under the department that manages behavioral health MCOs. So the idea is that if you identify a behavioral health need for one of your residents, you should be letting the service coordinator know that you have identified that need. They are supposed to then be in communication with their behavioral health service coordinator, which every plan has to have, and they're supposed to be coordinating those services. So I think this is an area that we haven't, like Denise said, haven't really tapped into too well at this point, but I think there's a lot of confusion as to what services are available, how you access those services. Does the resident have to go out of the facility to get the service? Can services be brought in? So those are a lot of questions that we're asking, and we're trying to get better information. So hopefully we'll have that information before implementation in the Southeast, and it might be a better ramp up than for the behavioral health portion of this program. So.
Thank you, Denise. We do have some questions that have come in now, and we'll read those off.
How can we get a copy of the logs? We can probably get them from Denise, and then we can send them out to the attendees.
Sure.
Yeah. what specifically does the CHC behavioral health do for the residents? How does this benefit the SNF resident on this or the SNF itself? Great question. Honestly, that's we're still working through that. I don't really have a good answer for you at this point. That is an area that we are involved in with the behavioral health MCOs, and if you're at our annual convention, I would suggest you might try to sit in on that panel conversation. That you might get good information there. And we also will be updating any Q&As that we have, any information we have in our Q&As on the behavioral health program.
And we probably want to make the behavioral health panel a large room, because you're going to have Southwest PA as well as Southeast PA sitting in there trying to figure this out.
Take a note of that, Wendy, right?
Totally noted.
Okay, so we have another question. Slide 31, can we get a cheat sheet of the requirements per MCO? Otherwise, each provider will have to get this information separately, and I'm sure the requirements are the same. I have to go back to slide 31.
I think that was on the billing.
I think each of the MCOs have to have a provider handbook where that information should already be available. We can try to look to see if we can pull something together as a side-by-side, but I'm not going to promise anything at this point. But that's definitely a resource that we can look at maybe developing. Katrina, did you have any suggestions on that? Because I think that was one of your slides.
What was it again?
They wanted to know if they can get a cheat sheet of the requirements per MCO. They're referring to slide 31.
I mean, there's none out. There's no cheat sheets out there. I just kind of, as I went through, made my own notes. But the facility, the MCOs, they're going to do the provider manuals in there, and your contracts will also have what revenue codes to use. And that's basically what I consider my cheat sheets. Is I just kind of went through the contracts, highlighted what revenue codes needed for each MCO if they were a different revenue code, which would be a different type. And then, but as far as them providing, they have their provider manual and your contract.
Thanks, Katrina. And I think Denise just made a good point here that, when phase 1 was implemented in the Southwest, the provider manuals weren't available. So that was a challenge. I think that's some of the challenges that our members had. But you have access to those provider manuals, so you might want to go in there and start looking at them now to kind of prepare yourself for those conversations with the plans, and to kind of know what you're going to be getting into when you're working through this program.
Okay, are there any other questions? You can go ahead and type them in. We'll move on to Gail Weidman is going to provide us with some resources.
So we have a number of slides that just have a list of resources on them. I just wanted to draw your attention to them. We do have on our PHCA website, we do have a number of resources that are specifically for our members. We have our Q&A document, which is all-encompassing, at least I hope it is. We include the questions the questions we get from members, the questions that we have of the department, the answers we're getting, as well as some of the questions that the department has on their website that are related to our nursing facility members. There's a lot of links in that Q&A document that refers you to the agreement, where you can find information on the agreement, where you can find other resources that are related to those questions. We have developed a table related to the 30-day benefit, because I know that's been a real challenge for members as to knowing who pays for what when someone's MA pending and you go back retroactively for payment. So all that information is in that Q&A document with a lot of links. We also have a contract provisions checklist that we developed with the support of Post and Shell, one of our business partners. We work together to come up with a checklist that our members can use as you're having those conversations with the plans and you're developing those contracts, the kinds of things you want to think about. You want to think about a lot of the things that folks have talked about today, your rates, how you're going to work with the service coordinator, how they're going to access your MDS, how are you going to deal with events, transitions, when you have someone transitioning from one plan to another, all that information, all those things you need to think about when you're developing those contracts is in that checklist. So that's available. We also have the provider agreements that we did, the Post and Shell did a review of the provider agreements that initially came out in phase 1. That might be somewhat helpful. And then we also have a newsletter that we produce. We try to do it quarterly. The last one was done this in July, just a few weeks ago, and it basically was all about contracting. It's a lot of, there's a number of articles on contracting, what to think about. The checklist is in there. So there's a lot of information that we hope that you'll use and will be valuable to you. You also have access to the PHCA staff. If you have questions or issues that come up, we're here to help you guys as well. So as a PHCA member, you have access to us. And then there's a number of resources on the department's website. Here's a list with links. There is a training that I think Kim mentioned that's basically a 101, CHC 101 training that if your staff are not familiar with CHC at all, it might be something that you want them to just listen to and view as at their leisure. It kind of gives them an introduction as to what it is and how it might impact your buildings. So that's all available on the department's website. I think we also have links on our website to all these things. Again, there's a lot of provider documents that the department has developed on specific issues that seem to be that continue to come up. There's some flyers on. There's some informational flyers. There was a lot of confusion of what is CHC versus health choices. So that kind of information is all out there on the department's website. And then there's information on service coordination, continuity of care. So that's all this information. I'm just kind of going through here. Billing, resources, and all the contacts for the MCO plans is all on their website. So I know I did that quick, but I wanted to make sure we had enough time for any more questions. If you have questions that come up, this is kind of one of my main focuses right now, trying to get you guys through community health choices successfully, and I'm actually happy to do anything I can to help you through this. Please reach out to me, call me, or email me if you have issues that come up, and we're happy to assist in any way we can. So,
great, thank you, Gail. If there are any questions, please type them into your question pane. I don't have any in the queue right now, but if you do have questions, we still have a couple minutes left on the webinar. I'll see if any of our panelists have any other closing remarks while we're waiting for questions.
Want to go in order?
Yeah, go ahead. You're closest.
Okay, since I'm closest, I would just say that as much as you can do to utilize the links that you were just given some, previews of, I would click on them. The department has a lot of great one-pagers, so it's not like they're all complicated and, full of detail like a federal bulletin, but they're really going to be able to be something that you can print off and share with your team, and they're really great resources to you. The frequently asked questions are also extremely helpful, along with the newsletter that Gail and the other team members at PHCA puts out. But I really would challenge again that you're going to be able to download the provider manual and really kind of go into the detail, as much detail as you would like. You can split it up between your different team members as to their area of expertise, to just really take a look and see what are the expectations. There's a lot to it, but I think that a lot has been really played out at this point and vetted through. So make sure that you're utilizing all your resources so that you can have a successful rollout.
I would say two comments. One is, as you do your contracting and your work with these three different organizations, I would just point out that Centene's the largest. They've had a lot of experience coming into MLTS. Emeritus has had some, and UPMC has none. But at this point, they've had the first phase experience, so I can't imagine that all three would be better going into phase 2 and 3. But each are very different companies to deal with, so I just give you a heads up on that. Then the last thing is, billing went pretty well. I think we spent a lot of time talking about all the bad stuff, which is, of course, we gotta think about these things. But billing went pretty well. The service coordination was very rocky. It's gotten better. I wouldn't classify it as still good, but it's better. And I think a lot of that has to do with, as Kim said, many of them had no skilled nursing experience. It was the first time that I think they'd ever walked into a nursing home. So I think over time, as they learn more, and I think a lot of them had fallen out, and we've had people now more in place, I think that the service coordination has gotten better. I think the struggle, and as you contract, somebody brought up the points of transportation and DME, vent, and respite. I would make sure you have those nailed down in your contract discussions. Those are the ones we're still wrestling with, and so if we're still wrestling with them, I think it's a good thing for you to talk about them in your contracting as well.
Checking in with our other panelists, Tammy, Katrina, Shelley, Kim, any other closing remarks from any of you?
No.
This is Kim. The only thing I will add is that please start contacting your physicians and educating them, because when this first started and I was having discussions with medical directors about community health, their answer was, "What are you talking about, community health?" They'd never heard of CHC. So you really need to start doing some education with your physicians too, so that they can seek out those contracts and be able to provide services for your residents.
That's a great point. Thank you for raising that. We appreciate that. Again, if there are any questions, please type them in. We've got a couple more minutes. I do have a question that has come in. What stage of the contracting process should a facility be at, knowing that the January 1, 2019 date is rapidly approaching? Applications have been submitted along with credentialing. However, contract talks so far on the facility end. I'm not sure that's a complete thought there, but I'm not sure who wants to take that. Answer it on.
Hi, this is Tammy. First of all, when we went through this whole process and had everything submitted, we were given deadlines constantly about rates. When would they have the rates? When would they have the executed contract? And they would come and go. So I would think at this point, since they've been through phase 1, they're going through phase 2, it might be a little bit of a quicker process. But you're on the right track if you've got everything in as far as your credentialing. You know what rates should be in. You've had all discussions regarding all of your different rates, transportation, vents, if you have them, whatnot. What I would do is, once you get all your documentation in, I would call weekly just to see where they are with the process. Just contact that person, your direct contact for contracting weekly, just to stay in touch and stay on top of things. I don't know if anyone else has any suggestions, but that's what I would do.
Contracting. I'd caution everybody on the contracting. I know you want to get it done, but we waited almost till December to finally ink a deal. Just be cautious to be too anxious, to make sure you get all your questions answered and exactly the way you want it first before you sign something. I know they're going to be sign. That's they're going to start talking to you. If they haven't already, they're going to talk to you that way right now. So, but I would just caution you, just take your time, make sure it's right. And like I said, we got ours done in December. which is a little late, but first phase, I think that's probably okay. But you should be maybe November.
Right, and this is Gail. There's a continuity of care provision and there's any provider provision. So anybody that's currently in your facility when implementation occurs, they have to pay you for that resident. So even if you don't have a contract, they can pay you as an out-of-network provider. So Mark's right. You need to take your time, make sure that you have all your T's dotted. No, your T's dotted. Yeah, your I's dotted and your T's crossed. Don't feel like you're in a rush to sign that contract. I only wanted to raise one other thing around transportation. I know our understanding is that they are changing how transportation is going to work in the Southeast compared to Southwest. There's been a lot of confusion with the transportation and how it's not really working very well. There's a lot of missed appointments and all kinds of things. So because they've had to deal with the transportation broker, it sounds like from what we're hearing is that that's going to change. The facilities will not have to use a transportation broker. They'll be able to continue to coordinate transportation as they have historically in their buildings. You won't get paid outside of your per diem rate for that transportation, as kind of happening now in the Southwest. There's just some confusion around all that. But as a plan, they're responsible for coordinating transportation. So when you're having those negotiations and they won't pay you outside of the rate for transportation, I would raise the issue with them that you're coordinating that transportation, which they are ultimately responsible for. So you should be getting paid for coordinating that transportation and maybe get a bump up in that rate. I mean, that's just something to think about when you're having those conversations. So I just wanted to add that. We also just wanted to mention that we are having an event October 4th at the Valley Forge Casino Resorts. It's going to be with all three of the plans. It's going to be only for nursing facilities. So that's going to be an event that you're going to be able to hear directly from the plans, more details around their processes, claims, service coordination, contracting, and all that. We will have that registration up
open soon.
So that's just something to keep your eyes open for.
I want to thank the members that we had speak today. Thank you, Mark, Denise, Kim, Tammy, Shelley, Katrina, Sherry, and Gail. This was, I know it's a lot happening and important information. So we really appreciate everyone's willingness to share and to help others. While we're waiting for questions to come in, we do have one question. Please keep them coming. We have a couple more minutes. We can end this early, but we do have one question that has come in. In comparison to the MA rates, how does the rate negotiating compare? Higher or lower?
So this is Gail. There is a rate floor that was negotiated, and that's basically a starting point. It's going to be the average of your 4 quarterly rates prior to implementation of CHC. So that's going to be your rate floor. You can't get paid anything less than that. But what we're trying to encourage you to do is when you're talking to the plans, see what you can do about getting an increase, getting a bump up of that rate floor. You want to talk to them about the transportation piece. You want to talk to them about the share piece, any of the event supplemental payments. Make sure that if you already are getting them under fee-for-service, that you continue to get some increase, get that little bit of a bump up in your rate from that.
Okay. Thank you again, everyone. We'll be sending a survey. Please go ahead and complete that survey, and the presentation will be made available on the PHCA website. Thanks again to our speakers for presenting on this topic, and have a great day, everybody.